Welcome to another episode of the Melbourne Athletic Development Podcast. We are very lucky today to be joined by Paul Coburn.
Paul, do you want to, instead of me trying to introduce you, do you want to give us a bit of a background of who you are, what you've done, to give some context for the conversation we're going to have?
Okay, well, thanks for having me to start with. I'm a physiotherapist and work out at Mill Park Physiotherapy, so we've got a clinic out there with about 14 or 15 practitioners, depending on who's pregnant at the time.
Jeez, it's grown.
Yeah, it has grown a bit.
Yeah.
But I also have worked for quite a while for Worksafe and TAC as the clinical lead.
What got you into that?
Yeah.
What got me into it was prior to that I worked in footy, worked with Richmond for 9 years. And just towards the end, and then I moved into doing some work at the uni, as Jack is doing now. So I was working at Lateral. So I ran the Master of Sports Physiotherapy course out there in the early 2000s for 2 years. And but while I was doing that, I just had a bit of extra time, and a friend of mine said, "Would you be interested in working at the TAC?"
When they came across, were you actually interested? Or were you like, "I'm not interested"? Like,
not really.
We always tell people this because they probably think that we're idiots, but we do basically no compensable work.
Yeah.
Right. And I'm sure you can tell us some of the stories, but generally it's because of the experiences that you have working with some compensable patients. Not all, some are great, but some are just malingerers and you just can't get rid of them and they drive you nuts, and you got lawyers calling you asking for details and you're saying, well, the patient's just not playing ball, like I'm calling them up, they're not turning up to appointments, and then you know what it's like. So did you have that thought, or were you like, nah, this is interesting?
I had the very thought that you just said. And I hadn't seen a lot of compensable patients in the last few years before I started working there. And
the other end of the spectrum when you think about being in sports medicine or high performance too.
Yeah.
Yeah.
So, and it's interesting to talk to you guys today about what we're going to talk about in the future, in a little bit, because you've got that dealing with people who are highly motivated and often really good athletes who know their bodies. But what happened was that I started off fairly negative about it, but I was working with one of the top sports physicians. He was working there at the time, Peter Harcourt. He's still involved a lot in sport now. He's just retired as the chief medical officer for the AFL, and he's on all these committees overseas for drugs, concussion, all sorts of things. But he said, come and do it. And the thing about compensable, the position working there, is that you get to see the overview of physiotherapy. And even though these cases are complicated, they're actually, in lots of ways, they're interesting if you're not caught up with all the paperwork. But for us as physiotherapists, the paperwork drives you nuts.
Well, I think that's the thing that detracts. But you're bringing forward a point that I think is pretty interesting, which is, I think to get good outcomes in patients, particularly if they're not motivated, you actually need to be very good at what you do, right? Or at least understand the process pretty well. And so Jack and I were talking about it before this. Like, have you sort of got a very different appreciation now for healthcare practitioners that can work in that space and get consistent outcomes and consistent successful outcomes?
Yeah, look, there's certainly, I've come across some who are brilliant. They're not necessarily, some of the best sports physios are incredibly skillful it takes a really high level of skill. And I guess this is, today I guess we probably should talk about the topic, just to sort of...
Just let it flow, mate.
Let it flow, all right.
Yeah.
No, but the thing is that there's different ways of managing different groups.
Yeah.
And so I've had some conversations with Jack, interestingly, offline, where he's brought up some things that I thought, oh, that's interesting. And we've spoken
about...
What kind of
stuff? Jack says a lot of things.
One of the things is
we're talking about physiotherapy related stuff here.
We are, good point. Not those things. But the fact that should treatment be individualised or should it be packaged into into specific blocks. And this is we had that discussion about 3 or 4 weeks ago, and we thought, oh, that's a good point. And it was good because I've been thinking about it a lot since. For the development in my opinion, for the development of our profession and health, you need people who are doing cutting edge, really high level stuff, because that's where the innovation comes in, and that's where you can really look at what can we actually do, and particularly with motivated people. But then to get the group, but when you're looking at a group, you may need a different approach.
Yeah, it's interesting. I've thought about this too with some of the
or less
conversations
motivated,
we've
sorry, as
had,
a group. Yeah.
And even from the email that you sent with things that we good to discuss. And the conversations John and I always have is we always think about how we can continue to improve ourselves and the clinic that we work in, and then effectively the profession in large. And I think the difference often too is thinking about how you work on developing yourself as an individual versus how you work on actually building up the overall profession. And I mean, I think this often comes down to thinking of, from an education standpoint, of like, what's the appropriate way we go about teaching certain skills or foundations at a tertiary level that we make that then allows them to continue to expand on their skill set later on. And this is actually a conversation we had recently with another person we had on, Richard Fernandez, who's an anatomist at Latrobe Uni. I don't know if you know him or not, but I think it was one thing that I probably took away from that is it is quite a process to develop certain skill sets and knowledge, or at least how you actually approach developing skills and integrating that into your clinical practice. And perhaps we need to think a bit more, well, I thought perhaps we need to think a bit more about what you should be getting from an undergraduate level from, say, as opposed to, say, a postgraduate level. That there's actually
something that Richard Newsham-West sort of spoke about.
Do you
know Richard?
Yeah.
He spoke about it because obviously he's heavily involved in the postgraduate course, and I probably hadn't thought about it, like you're saying, Jack, as much of. Basically, you're so green when you come out of your undergraduate, but you think you know everything because, Dunning-Kruger effect. And then it's not until you've got a few years down the track and then you do maybe some extra study, you realise, oh wait, okay, there's much more behind the curtain.
Did you feel though confident when you graduated?
Oh, hell no.
I would say, because I didn't have
I feel
that
like a
feeling
dummy when I graduated.
Well, one of the reasons why I used to work at Mill Park with Cobes is one of the reasons why I wanted to go there is because Lachlan Giles worked there, and he said it's a great clinic for new grads. And I remember thinking, I've got no idea what I'm doing. Like, I need to go somewhere where I can actually build up some foundation knowledge, because I didn't feel like I got that from my tertiary degree. And part of that, I think, is also related to the fact that a lot of the physiotherapy program is based around the public hospital system, which the structure that you follow is quite different to what you see in, say, private or sports. But yeah, I guess this is probably an important conversation to have, is like, what are the kind of things that you think we need to develop within our profession to actually better improve the outcomes of like what physios do, and obviously the outcomes that we have with patients.
Well, that would lead into what we're going to talk about today.
Yeah,
well,
go for it.
Where do you want to start?
Well, one of the questions we spoke about was what's happened, how the profession's changed. And I thought, as soon as I start saying that, I'm going to just bang on, like,
Good.
old.
We want to hear what you have to say.
Yeah.
But what I was going to say is that it does actually also, there has been a lot of things that have changed. And I think what it does is it creates a whole set of new problems. We've solved a lot of things, and it's been fantastic being a physio in this time to see all the things that have changed. And I don't know how many more years I've got of working, but I'd love to see what happens in the next generation, because having seen what's changed so far, I think it's going to be amazing.
What do you think the main things that changed for you across your career?
So what I saw, so when I started uni, I was a bit shocked about how little evidence there was in the job that I was choosing. I remember talking to a GP cousin of mine towards the end of my course and saying, well, I really don't know what we do that actually works.
And when you say that, what do you mean in the sense, because there's literally no literature to support any particular interventions?
If you look at Pedro, I'm pretty sure around about, so I was in that period between 84 and 87, but Pedro, as you know, is that physiotherapy database, and it goes across a lot of things. But anyway, I saw once an academic put up the number of trials, clinical trials in musculoskeletal medicine that would have been around when I was at that. You can actually plot it. I've done it myself. But how many around at that time when I was a student? There was 400 clinical trials in musculoskeletal. And I'd done exercise science at Melbourne Uni before I did physio. It was called Human Movement Studies. And when I did that, exercise physiology was still regarded as a novelty in the medical school. So at that point, there's 400 trials and exercise physiology. It really was like a hobby for the people interested in sport, but it wasn't a true. They actually said it wasn't a true science. God. Anyway, so what's happened since then is I think there's now about 18. Last time I looked, and it's probably gone up because it's growing exponentially. It's about 18,000 clinical trials, not 400. So you probably could have, if you got going, you could have read all the clinical trials in physiotherapy in a couple of weeks. And so the explosion of knowledge has been phenomenal. That's probably the biggest thing that's happened. And it's hard to understand that now. You haven't gone through this thing thinking, I don't know if this profession has got any legitimacy, because it's
I've thought that.
but from a different perspective, but then, so that's one of the biggest things that changed. But then it just created all these new things to deal with, new issues. And they are things like the fact that with all that knowledge, how can you keep up with it? And if you want to work if you want to be across things, how the hell are you going to deal with all the information that's coming up? My area of interest is hip and groin injuries, and it's just the amount of stuff that's coming out every month is overwhelming. So that's one of the issues that it raised. I mean, we can talk about a lot of other ones, but...
Well, no, staying on that, how do you think we go about dealing with that? Because the fact is there is a lot of research coming out, both applied and, basic research. How do you think we actually integrate that into what we do clinically?
Well, I'm interested to hear what you two have to say about this. Because where I'm coming from, it's basically specialisation. But there's a problem with specialisation, and that is that when you start specialising, you sometimes miss the basic science, or so you start to lose...
You lose perspective.
Yeah, lose perspective. Thank you. So you can become too narrow.
It's interesting you say that, because I often think that a lot when you hear... This is not everyone, but you hear a lot of specialists or experts who've done their PhD in a particular field, where when they introduce the work or the topic, they'll talk a lot about the basic science, whether it's related to, say, the anatomy of the area, understanding changes and adaptations, and you can clearly see that they have such good understanding of a lot of those basic sciences related to that particular topic or problem. But then it's interesting when they talk a lot about then, particularly from an intervention standpoint, they focus a lot more on the applied research, which I can understand the reason for that, but it's almost like they've just neglected all the basic science that they've talked about.
Yeah.
That understanding that area of the body, and I always find that a bit of a mismatch, really. And I hear that in a lot of particular... It's interesting, John and I have talked a lot about tendon and connective tissue behaviour recently, and you hear a lot of these tendon gurus and experts talk about it, but then a lot of the time it's like all we do is sort of heavy, slow, isometric contractions, which clearly has therapeutic benefit, but at the same time too, it's probably not the only thing that we need to be considering with, say, developing the properties and capacity that tendons need in order to be able to deal with, say, high force, high velocity contractions needed in a lot of sport. And it's something that I've questioned myself and thought, is there an issue that we have where we focus too much on only looking at the applied research and typically the high quality studies, and not using some of that basic research to fill in the gaps or develop universal principles that we can actually apply?
We spoke about this beforehand, but we're talking about the basis of even what people use as their support structural paradigm, which is evidence-based practice or evidence-based medicine. And I don't think actually, when a lot of people talk about it, I don't know that, and this is a gripe that we always bring up, but we don't know that a lot of them even know what the foundation of that was and where it came from.
Like the Sackett stuff.
Yeah, have they actually read the papers by Sackett? And we're talking even about the really interesting papers that were done between Sackett and, do you know John Ioannidis? He's
No.
an epidemiologist from Stanford.
And meta researcher too. This guy's a genius.
Yeah, but yeah, he's a polymath and he's published more than 1,000 papers.
Yeah.
He's got the most cited article in all of the medical literature.
Yeah.
There's a 2005 paper saying why most applied research results are wrong, something like that.
Okay,
And
yeah.
you can imagine.
Because of statistical reasons.
Yeah.
But essentially, if you look at that model, it was a 3-part model.
Yes.
Right? And only one part of it was the literature body.
Yes.
Right? Yet it seems, and you would have seen this because you would have gone through the era, whereas like clinical experience was a big part of the decision-making process. And that's 1/3 of it. The other third is patient values and expectations. And then the last third is, as I said, the literature body. But it's become, in my mind, the way I see it, it's almost like people think 90% literature and then sort of 10% the other ones. And what that's flipped for me, and even the discussion we have with Jack, is I think what physios do well, and we had this discussion actually with a surgeon, she's just finished an orthopedic training, is surgeons have a very similar mindset, I think, to what physios have, which is a little bit experimental. We like to kind of explore our knowledge and we'll use and adapt things as we go. Now, I think we're lucky we're not in the case of someone's under anaesthetic
Life
and
or death,
you cut their leg off or you don't cut their leg off or they
Yeah.
lose nerve function. But we're willing to actually try things. We go, okay, based off that research that I read, and as Jack was saying, off maybe some of the basic science, like I know tendon, the viscoelastic, function of it's like this, so I'm willing to maybe try this kind of rehabilitation. And that to me is the foundation of that kind of clinical experience, development and exploration. Yet, one of the big things that I think I struggle with currently with the way we teach students, and even the way that maybe you have to operate in the framework that you're working in.
Yes.
They say you have to follow this protocol because there's evidence for it. And to me, that actually takes away from the evidence-based practice model if you actually follow the model that was proposed by Sackett that we have so-called adopted as our framework. That to me is a mismatch as well. And I don't know what the answer is, but to me...
let's talk about it.
Well,
I think that I think that's a great thing that you've raised. An important issue you've raised for us. I agree totally. It's all about the evidence, not about the other two things. So,
well, and it's the issue too. Like even the language we use, where a lot of the time people will say, like, "Is it evidence based?" And they actually, what they mean is there research behind it? But that term has really been hijacked just to relate specifically to the literature and specifically the applied literature. But it's interesting too, because I know from your work with doing TAC work cover stuff, maintaining some certain standard of practice I think is really important, because I imagine you get a lot of insight into what some people are doing and you're going, what the hell are you doing with this patient?
Yeah.
In terms of the
Taking
standard of care actually
yeah.
being woeful and maybe not even doing some of the basics correctly. So I think there's an issue in that, in the sense of how do we make sure that there is a certain standardization so that we actually improve the overall profession, but then how do we make sure that we allow, like what you were saying before, the people who are quite innovative or creative to actually keep pushing the boundaries, because I think they're often the people that create the theories and observations that then ideally talk to the researchers to go like, look, this is what I've been doing, this is what I think, should we work on actually doing some project to see if I'm right or full of shit?
So this is the question you raise is the one that's been bugging me since I started working in the compensable area. I was always worried with our frameworks that we'd inhibit development. Because in theory, if you only do evidence-based practice, then that's where it stops, because no one should do anything else.
Exactly.
You shouldn't actually learn anything else, because, look, we can only do what's there in front of us. But some of the things that we've come across over the time, the first thing I'd say is, we do see a lot of care that is suboptimal. But usually it's from well-intentioned individuals, even though we look at them and go, what the heck, you're an idiot, or you're exploiting the system. But they're not, most people aren't like that.
You know what I think it would be doing, and this is why the outcomes they're getting are probably not that bad, is they may be even meeting...
they're not getting good at outcomes.
Well, but what they may be doing is actually meeting some of the expectations and values of that patient. And like...
Exactly.
And, some patients, as you know, all they want is manual therapy. If they're not getting manual therapy, particularly in the compensable space, they're going, why am I even bothering? Like, I can go do exercise myself. Or even though we would very heavily argue, well, that's actually, there's support in the literature for doing this kind of exercise intervention. There isn't maybe for, doing 25 manual therapy sessions in a row. But people will do that because the person actually asks them for it or says, I really feel like I need this. And how do you balance that?
And more importantly, it's like manual therapy is an interesting one because like the amount of debates that go on, say, social media of manual therapy is a waste of time, there's no literature. Yet it's interesting, a lot of people still actually use it, and even actually a lot of people I have a lot of time and respect for, who you would think like, oh, isn't there no literature for it? But clearly there's clinical benefit for it.
Well, you would actually, this is an interesting question for you because you've been through this evolution. When you studied, manual therapy skills, I think, were much more well developed in the cohort of students than what it is now. Now, we have students come through, and I'm sure you guys probably do at Mill Park as well, and their manual therapy skills are horrendous. They spend very little time developing them because they're told there's not a lot of strong evidence for manual therapy techniques.
Yeah.
Right? And so I think that they actually take that in and neglect it. Right? But then they come out into the practice and we're saying to them, well, try this and feel that. And you actually need to be able to understand, Jack's very big on understand the surface anatomy so that you can actually be better at your diagnostic skills and so that you can do this. And you actually need the tactile skill set to be able to do that.
Yeah.
Right? Which is part of your manual therapy skills. And they don't quite get that connection.
Well, yeah, I see that at Latrobe. I've been teaching MNIPS, believe it or not. And they've basically never had any exposure to MNIPS before, which is fine. But as soon as they get their hands on, a lot of them start freaking out going, I don't know what I'm doing, I don't know what I'm feeling. And part of that is the art of manual therapy in the sense that the only way you actually get really good at hands-on assessment and treatment is the regularity of actually building up your proprioceptive ability and ability to identify landmarks and work away from that, let alone then going, well, how do we do a manipulation? Besides whether you think manips are good or not, but there's obviously an art to actually being able to position someone into that. And it's one of those things where you can read as many books about the theory of manipulation as you like, but you're actually not going to see the result until you actually get regular exposure.
Yeah.
And as someone, like, you worked in sport, so you know how this is. If you try and remove manual therapy from athletes, they'll label you straight away as a terrible therapist.
Yeah.
So
that's patient preference.
Yeah.
Going back to your original point. So let's just jump back a couple of steps. So the question is, and you've pretty much poised it, that first of all, how do we encourage innovation, and how do we see that that the individual experience also of the clinician in the SACET model. What we've done at WorkSafe a couple of times is through some projects actually looked at individual and performance with a cohort of patients. And we've also looked at some clinics' performance, comparing them. So with the interesting thing is that we discovered that we had a couple of clinicians who probably down the lower end in terms of understanding evidence-based and were definitely the best people at getting people back to work, right? So those two individuals were often regarded by some of my more academic colleagues as being rogues until they started seeing the results. And even then they weren't prepared to see their believe their results. But they were getting improvements. Now the thing is, you need a cohort of patients to do it. But we are so obsessed with evidence, and don't get me wrong, the importance of it. You need to use it, and you need to do basic sciences, but that you need to you also need to recognise that individuals have an impact, but you've got to measure it, because it's the same argument. Just to let me finish. Go. The trouble is that we've got good clinicians. We've got these people of really high performers using the same argument as ones that are poor performers, saying, I do it what I feel. So if you don't distinguish them, it all becomes a mess, and it actually detracts from those who are actually really good at it. So the first thing is, and it's not that easy, but it's actually trying to have a cohort of patients and then measure individuals' performance with that cohort. And with WorkSafe we can do it. It's actually really hard in sport because you're so close to the ceiling effect a lot of the time. You're really pushing up against it. You've got a lot of clinicians trying to get those last few millimetres, and minimal detectable change in that could be 0.1% that makes a difference. Really difficult. But with us, we can do that. So that's one of the That's one of the important points. But then it raises that other question, again, you've put it, the patient preference one. And the patient preference one is the one that I'm not sure I know the answer to, because we've still got patients who want the manual therapy.
Yeah.
And a meaningful clinical benefit is not necessarily what a patient wants. So like, there's been studies done on, patients who, for example, have had babies and they put them in 5-star hotels. That's kind of, for their post-partum management.
Yeah.
That's what they want. They want 5-star hotel management, not making sure, if anything goes wrong, you're going to stop them dying. So you've got all these people saying, my care was fantastic because, I get, a decent latte for breakfast. And I don't, so how do we, that's a patient preference.
Yeah.
And then going back to the last thing, just that thing on the manual therapy, the real problem with manual therapy, and Jack, I'm not telling you anything, but it's just a hard thing to research. Like when you talk about evidence-based, not all of the evidence-based processes or evidence-based studies can allow for some of the things that we do, like in the short term, as a benefit.
Yeah.
Yeah, so, I think the other part of that too is like, how do you quantify something like the feel, of the hands-on? And I think too, there are some really brilliant manual therapists out there, but it probably takes years to actually build up those skills. And so the problem is that actually transferable on a large cohort? And I probably agree with you there when you think of like, if we needed to prioritize what interventions we use, I don't want to dismiss it completely, but manual therapy probably wouldn't be the highest, would it, in terms of thinking about utilizing
you're right.
more active interventions?
Yeah, but Tanya Bazzari did we're talking a bit before about trying to keep your scope open. So I try to avoid shoulders. I've got no idea, but I try to go to our regular seminars, etc. And oftentimes you learn something in principles from someone else. Tanya Bazzari did this presentation on shoulder assessment. So obviously she's, I think she's over 140 papers. She's an associate professor. She demonstrated these shoulder techniques. And she said, look, just forget for a minute. She said, like, we can talk about the sensitivity and specificity of all of these techniques. All of these
tests and things,
examination techniques, But she said, but then you've got to work out what you're going to do. So what I'm showing you is the manual techniques that I use to direct me in the rehabilitation, because then I know which way to go in terms of exercises, etc. And it was actually interesting seeing that perspective.
That brings to light something that we talk about a lot, which is using principles that you can apply across different parts of the body. And I know that Jack and yourself have had this discussion at some level about the difference between generalization and specialization. And I think we fall on more towards the side of being a generalist rather than a specialist. And it's for this simple reason that I think we very much see that if you develop these underlying principles, you don't need to be a specialist, because what you're applying, the specialization is in being able to identify and use principles that are universal for, say, the human body.
Yeah.
If you're looking at a joint and you're manipulating it to go, okay, well, I'm seeing that this is happening here and I need to work out whatever it is. So that means that the movement that I want to be able to rehab is this. That's no different in a hip, a knee, an ankle. It doesn't really change. So do you need to have that mentality of I need to really know the nuts and bolts of this, or do I need to know the nuts and bolts of how I build a structure of my assessment and build a structure of how I then apply that assessment to my rehabilitation?
And I would say to add on to that, and also know the context of when you do need specialization. Like for instance, if someone comes in with some complex hand injury, I'm not going to be the person to see them.
That's
or
right.
like the other example is someone comes in with an ACL rupture and you think they need surgery. They obviously need to go see an orthopedic surgeon or medical management or whatever it means. So the question I often ask myself is, does this presentation fit within the scope of needing very specialist attention? Or does it fit into, like I think a lot of injuries, particularly in the general population, falls into this kind of, maybe not necessarily non-specific, but I can identify that there's no clear structural damage that needs specific attention, and therefore I need to change my framework to understanding the why and the how. And that's something that John and I utilise and talk a lot about, is this idea of complexity and actually creating a framework. We use a framework here in the clinic more so that to make sure that we actually have something to make sure we don't fall into our own bias.
Yeah.
So because the issue is we all have
Yeah,
biases.
yeah. Oh, don't
so
we?
it's one of those
Yeah,
things.
no, it's absolute.
We create a framework, so it's like, have we actually covered all the main areas, whether it's related to, say, their tissue capacity, their biomechanics, lifestyle factors, when you think about, sleep, physical activity, obesity, comorbidities. Have we actually covered all the bases that we think might be contributing to this problem? Because I think the issue is, and you sometimes fall in the issue of it, of going, this person's not getting better. And then you go back to the framework and you go, oh yeah, right, I
missed this, yeah.
Yeah, I haven't even looked at their mechanics and movement or whatever it may be.
Yeah, absolutely. So I reckon it's interesting you say that, because that was sort of one of the other things I was going to talk about, is what's changed. So I spoke about the evidence. The other thing is the biopsychosocial model. And the biopsychosocial model, I think, has been great for physio, even though when it first came in, a lot of people were sort of, it's all psychological. And it turns out it's not all psychological, but it's a big factor. But if you look at something, say, like a hip injury or a hip OA or whatever, oftentimes, that a good hip surgeon will fix a lot of them, but they don't fix all of them. Yeah. And it's often because they don't have any skills outside of what they can do. So I would still go to see that hip surgeon, don't get me wrong, but a lot of patients might need, for start, is it a psychological problem? So we're not necessarily always using questionnaires. And is it a general body problem? Like, is the hip pain that they're getting not... I don't want to talk about the number of things I've seen operate on a WorkSafe TAC.
That don't actually require surgery.
Yeah, the best one was this week, or one of the best ones. This week, this patient, and I've only come in halfway, got a pain in the groin area, right? Had an accident 6 months ago, something popped at work. So I went to see the surgeon. The surgeon says it was a hernia, repaired the hernia, but he's still getting pain. So the surgeon's comment was, well, I've fixed the hernia, so something else must be injured. Which begs the question, well, what was there in the bloody first place, and to say, and have you just fixed an asymptomatic hernia, in which point of case was it actually broken? So, so in terms of getting your diagnosis right, and that's at a simple level, but at that broader level, so what you guys, I'm pretty focused on the hip and that sort of stuff. But in terms of, there's always different ways of approaching it. Maybe that person's whole system is out.
Absolutely. And I think that's where people, you can often roll your eyes on the biopsychosocial model, because people don't actually understand that your psychological state and your social relationships actually have an impact on your physiology.
Yeah.
And that's where, I think particularly when you think of general population, someone comes in, non-specific back pain, sedentary, overweight, like the classic type of presentation, and you get them to do general exercise. What is actually the main drivers to their improvement, assuming that they get better? Because the reality is, I'd say a lot of it actually has to do with how the physical activity is regulating their immune system, and through that the inflammatory response and their nociception.
Rather than the specific pathology of their back.
Yeah, don't get me wrong, you're obviously creating some structural changes through mechanotransduction. You might be building up strength capacity through the hip back. It changes the biomechanics and load distribution. But a lot of it also has to do with, as you contract your muscle, you're releasing all of these myokines, you're creating changes in the local and systemic inflammatory response that
makes you feel better.
Exactly, from a central level or even a hormonal level, they start seeing quite positive changes in how they feel. And it's interesting, I know you actually told the story about Zach, Zach's old patient, the one who had...
the shoulder problem. So we had a business guy, a super successful guy in the financial industry. He was really high up, CEO sort of level at financial insurance firms. Comes in, he's got really bad, shoulder rotator cuff tendinopathy, and basically, the whole, he's in his 50s sort of doing that thing to put his jacket on, sort of turning like this. So I don't know if you know Zach, but Zach
you actually had met Zach once before. You met him through Cody.
He's now working at the...
And you told me a funny story, because you thought that I remember actually telling Zach this afterwards because Zach was a very young physio and he was acting like he knew everything and you laughed at him. And I told Zach later, I'm like, Cobes had a good laugh at you because you thought you knew all your shit. And Zach laughed at himself going, yeah, the problem of the Dunning-Kruger effect was a young physio thought he knew everything.
But anyway, so he starts this rehab with this guy and the guy was, probably 15 kilos overweight. He was a very high level footballer, played sort of VFL, VFA stuff back in the day. And he started doing more exercise with Zach and he's doing rehab, but he was like, I wouldn't mind getting fit, so Zach's getting him doing all sorts of stuff, trap bar, and he's, gets him back to being able to do pull-ups and all this kind of stuff. And the guy goes, he'd come back after a few months, he was travelling all the time, and he'd come back in every now and then for a checkup and he'd do a rehab session. And I remember once he came in and we're in the gym together and he's talking to Zach and he goes, he goes, oh, you look great. And Zach says, you look great. And he goes, yeah, I feel great. He goes, and all this exercise, I dropped all this weight. And he's like, and my missus, she's loving it.
Well, because didn't Zach say to him, like, mate, why do you keep coming in here all the time? Yeah.
and the big thing was, after that, Zach was sort of laughing, but we had this conversation. I remember Jack was part of this conversation. We said, like, one of the benefits of resistance training and general exercise, particularly for males as they get sort of post-40, post-50, when their testosterone drops, is it actually increases the amount of circulating free testosterone. So he actually is going to feel a lot better.
Yeah.
And it's one of the main reasons why you want to maintain muscle mass as you get older, both as males and females. And I think it's to the point that Jack's making is, a lot of the time, we think that we're getting the benefit from strengthening the shoulder, but we're actually getting so many of these systemic effects that are hugely beneficial. And that is the biopsychosocial model. You're actually changing their psychology because you're affecting, you're affecting the biology of what's going on within the actual physiology.
Well, it's interesting too. Like if you look at, I don't know how much of Paul Hodges' work you've read more recently, but a lot of I actually am really impressed with...
Paul, if you're
watching. Sure, Paul Hodges, listen to this, hey. I'm really impressed with some of the evolution of his concepts and models of the sensory motor system, because a lot of what he's showing is some of the local changes that occur to the erector spinae with a vertebral disc lesion is fibrotic tissue formation. And that's also going to be manifested or amplified based on the overall health and well-being of the individual. So if they have markers of poor health and associated like low-grade chronic inflammation, they have more fibrotic tissue formation. That feeds a lot of those sensory motor dysfunction. And it's interesting, a lot of the stuff that he's saying now too is if we don't actually address some of these other health-related factors, i.e. obesity, comorbidities, you're not necessarily going to see the change that you want. And so I often think of that with, depending on the population group, it's going to be different for, say, an elite athlete, though they could still have issues with health and well-being. But for general population, when we see a decline in health and well-being, when they come in with musculoskeletal pain, what actually are the main drivers? Like, is it really related to the musculoskeletal system? I'm sure that there's an element to it. Or is it actually being mainly driven from other dysfunction of other systems? And I think that's something that perhaps we underestimate the actual power of physical activity on having quite significant effects.
You probably guys have investigated some of that stuff when it comes to outcomes. Have you looked at stuff like that?
For WorkSafe?
Yeah.
No, not general.
Okay. Really?
No, we still, I mean, I totally agree. What's these arthritic conditions, how much of it is inflammation and diets, and yet we're trying to bang away at that.
It's interesting, like talking about OA. I remember reading quite a bit of stuff about it last year.
Yeah, you presented. Jack usually does a number of PD sessions for our group week to week, and he presented a whole heap of papers through the middle of last year looking at obesity and the effect that it has.
And metabolic syndrome in general, because it's one of those things with OA where I know a lot of what's that? Is it the Danish woman, Roos? Like
Eva Roos,
doing a lot of research on looking at physical activity. But the other big thing that I think people misunderstand with something like OA is it's not just a musculoskeletal condition. Like so much of it is associated with metabolic dysfunction. And then unless you actually address that obesity or their blood glucose dysregulation or dyslipidemia, high blood pressure,
or even just low muscle mass people seem to get that. It's like that skinny fat idea.
Absolutely.
I think you see so much of it. Like, this is why I find it frustrating when, say, even an older patient who develops OA, who actually hasn't been particularly active throughout their life, they'll go and see a surgeon and they go, it's just wear and tear. It's, bone on bone from wear and tear. And you sort of think, well, this person didn't do much.
Yeah.
Right? So clearly for them, it's being driven much more by these metabolic dysfunction than it is by overuse.
And I think that's
you would have
where-
seen lots of athletes through your time, and Jack was saying that you were a pretty avid runner, and your hip plays up because of it.
Oh, no, Jack, it doesn't. Don't say that. It's not my running that caused that.
Oh, is it some others?
No, I think I think I got, like everyone, as a kid, I got a bump on my hip, yeah. No, because I don't have a job with the knees or my hip. And in fact, the one thing I can do is run.
Oh, okay.
So I'm getting a hip replacement in January, and I ran, 5K during the week.
I'll
so.
take it back then.
Yeah, no, it wasn't overloading.
Yeah, okay.
But can we just talk about it's going back to this. So I was talking before, keeping going with the theme about what's changed. So when I was an undergrad, there was not a lot of science around the benefits of exercise. And certainly the medical schools at Melbourne Uni were going, no, we're not interested. And when you think about it, they were looking at their model was looking at where people go from healthy to unhealthy, but right at that threshold. We're nowhere near, they had no concept of actually, if we push people away from that threshold, that we reduce that from happening. But in the time I've been working, there's been a total switch around of viewpoint on exercise, which is, for you guys, yeah, of course, but it wasn't like that. Most health professionals had no view on the importance of exercise for your well-being. But as a mate of mine said the other day, who's an old physio, he said, yeah, but bloody, you can't get people to exercise. It's a problem we're facing. And with the GLAD program, I don't know if you guys have run people through that, but so it's low level, and any physio I've spoken to laughs at those exercises.
They're so basic.
Yeah, they're so basic,
but it's successful because it's an entry point.
It is. That's and having seen people go through it, Eva Roos, we just spoke about her a moment ago.
Yeah.
She gives this presentation and she looks at all of the research done on knee osteoarthritis, and she says most people end up their presentation by saying we need more research. And she said, I'm ending this presentation by saying we had enough research 10 years ago, we should have stopped. And she's got lists, as it comes down the list of the benefits, the authors and how much benefit they get from the exercise. So what I didn't appreciate with the GLAD program, because I looked at it and thought, you're kidding me, is this it? What I didn't appreciate is that our first cohort of patients that went through it, there was one person highly motivated, but I'd asked everyone in our clinic to grab these patients who had some knee problems, and they got these absolute shockers who had more problems than just their knee. And I thought, this is going to be a disaster. So the only patient who didn't do well out of it was a highly motivated one, because she'd already done all the stuff.
Yeah.
Everyone else in that group, and someone in there had ataxia. I don't know, like early. They got better doing a regular exercise program in a group, and they also have an education session. So it's amazing how, what we're struggling with is, the three of us, if tomorrow the front page of The Age said there's been a breakthrough in science and we've discovered that exercise is actually bad for you, we'd still be doing exercise. We'd still keep going with exercise. It wouldn't change our viewpoint.
No.
Because it's it's kind of our lives. It'd be hard. It's like trying to give up smoking or booze. We'd struggle to give it up.
Why even bother trying to give it up?
Yeah, that's right. Yeah. But I think 80% of the population, it's a big effort for them to do exercise.
Yeah, well, it's an issue with the evolutionary mismatch where, through our evolution, we had to be physically
incidental
active.
exercise was part of living.
To actually survive, where now it's optional. And it's actually probably one of the biggest detriments of living in quite a luxurious society, because the reality is you can sit on the couch all day if you wanted to and basically get away with doing nothing.
We had this actually on that, and it's a similar point. We had this conversation. We have a student with us at the moment, but we also have a staff member who does some admin and sits on the desk, and he's a student as well from Latrobe. He's doing physio. And he actually asked us about Pilates. We don't really run any Pilates stuff here, right? And he said, it's really popular. He said, my girlfriend does it, she loves it, and all this kind of stuff. We said to him, okay, well, what is Pilates? And we're sort of going through, we're saying, try and classify it. If you're going to classify it on the, force velocity spectrum in terms of activity, what is it? And he's like, well, it's low force, it's pretty low velocity. I said, yeah, exactly. If you have a deficit in that area, do you think Pilates is going to be beneficial for you? He said, yeah, for sure. We said, great. And I said to him, what happens if your activity that you want to go back to, say, is playing...
Sprinting.
Yeah, playing hockey or whatever it is. Is that going to transfer then? And he said, no, not really. And I said, and that's the conversation that you need, because he brought up the fact that he's like, my girlfriend's been going forever and she thinks it's the greatest. I keep telling her she should go to the gym and blah, blah, blah. I said to him, there's no problem with it, obviously, but you've got to understand what you're using it for. If someone says that they're preparing the hockey team by doing Pilates only, then they're probably under-preparing the hockey team. But if, as Jack said, all you want to do is sit on the couch and, build a little bit more muscle mass or have a little bit more flexibility or have, better sort of movement around a certain particular joint or whatever it is, then Pilates is probably extremely useful for you. And as you said, it's an entry level that makes sense to that person. If you get someone who sits on the couch and they don't want to aspire to anything of great heights, asking them to go to Olympic lifts is a stretch. And we're probably pitching it too high. So that's kind of the match that you probably need to come to.
And I think this is sort of getting to the crux of how, at least I think about it, is there's no exercises that are inherently good or bad, so to speak. And I think that's one of the issues we have where, classic example, what's a good exercise for a hamstring strain? And the first question I often ask is, well, do you want to give me some context? And they go, oh, okay, they did it running. I'm like, okay, can you give me some more information? Like, oh, they're a 100-meter sprinter. Okay, can you give me some more information? They're 19 years old, and you keep going. It's like, well, what's their injury history? What's their training history? What are identified impairments that you think are contributing to it?
Yeah.
And so, hopefully these are just the nuts and bolts of what you do. But when you assess someone, you might be looking at their strength, you might be looking at their range of movement, you might be trying to create hypotheses of what is contributing to why they got that injury. And obviously you use the literature to support that, because you don't want to be getting too far away from going hierarchy of importance, is working on their, neck strength going to help their hamstring strain? Probably not as significant. But then the next thing is, well, what is the required mechanical tension or forces I need to apply in order to induce the adaptation that I want? And how is that specific to that individual based on their age and therefore their adaptability, their maturation in the sense of their training history? Because it's kind of like the GLAD program, like what you said before. It's actually probably going to be really effective for a majority of the population, because majority of the population don't do shit. But, for the people who are highly motivated, you're actually probably not going to induce enough stress to create any positive type of change.
Yeah, they're already beyond that level of physical stress.
And that's probably one of the concerns I have too, is often you see very intelligent people with good intentions present, and they'll often give, here are some good things for a hamstring strain. It's like, that potentially could be true, but context is everything in the situation of how much you apply, when you apply.
We had this conversation.
So evidence-based exercises for hamstrings.
Yeah.
How's that relevant?
Well, and because, we've found the perfect protocol that cures all hamstring strains or prevents all hamstring injuries.
Yeah.
We're not... There's a lot of evidence saying that actually hamstring strain injuries aren't improving. Now, you could argue that we're saying that a lot of sports are actually moving more quickly.
Yes.
So there's, potentially offsetting that.
But we had this conversation with Brady. We had Brady in, and he's talking about some of the injuries they're dealing with at when he was at Essendon, and he's now moved on actually. But and looking at the more complicated kind of cases of recurring hamstring strains and all these kind of things. And we're saying, and I know it's an area you want to talk about, but technology and how you're starting to get much more fine granularity about, okay, well, what actual deficits do they have? Is it a force output deficit? Is it something that changes under velocity? Is it in certain ranges that they
metabolic deficit?
Yeah, is it a metabolic deficit? Is it really fatiguing very heavily under repeated sprints or repeated contractions? Or is it a rate of force development problem? And we spoke a lot about the fact that, say, with these hamstrings, one of the things we're finding by using technology is that commonly the force comes back actually really quickly, but the rate of force development takes a lot longer. And so for those more complicated hamstring strains that maybe involve tendon tissue and things like that, it takes you a while to be able to create the ability for the tendon to deal with the velocity of movement. And so a lot of the rehab that we go shifts very quickly from high force activities, whether they're eccentric or not, to things that actually require a lot of speed. and a lot of time doing that to actually potentially change how that rate of force development occurs. And I think, as we said, that's something that you mentioned, that technology was one of the things that's starting to come across. And I think that's probably, even in our time, I think that's one of the things that we're finding actually is really changing our practice.
Well, even the ability to measure certain things with like a smartphone. Like for instance, we do a lot of, say, elastic assessment, looking at a depth jump. Now, you wouldn't have been able to do that long ago unless you're in a lab with force plates and all the fancy software on the computer to do that. But all of a sudden now you can actually do it, you can do it in your backyard if you wanted to. So I know that was something that you actually brought up as well. So what are the things that you are finding or you have interest in terms of, say, technology or wearable technology, and how we actually integrate that into clinical practice?
Well, actually, it's probably a topic that you guys could tell me more about. But I think the wearables, I don't think they're overhyped about what difference they're going to make to certainly to clinical practice, because in terms of measurement, I've been just recently grabbing people's phones. Sometimes they've got a watch, they don't even know how to use it, etc. And marrying up what they're telling me how they've been feeling with what comes up on number of steps or whatever they've taken. And it's amazing how poor people are as historians in terms of what they're doing. So
there's a lot of research on that, of people's ability to recall things accurately.
So that's, and it's interesting because we're also looking at what patient preferences are and using questionnaires so I think it's a combination of all of them. The question is, for me, is what is meaningful. So when, one thing that was around years ago was isokinetics when I was an undergrad, and I had a disaster testing one of our good players on isokinetics to decide whether he played football. Now they gave beautiful readouts, and but again, maximum speed was 300 degrees a second, and even that never showed any any prognostic ability subsequently. But we ruled out a player, and to this day he reckons I stopped him from winning the best and fairest. But based on his isokinetic measures, and I tell you what, one thing I learned was I've got to be really careful about what I think I'm measuring.
Well, I guess part of that though is, you ever make a decision based on one bit of data. Because I think the other issue we have at the moment is the over collection of data as well.
And
because
if you only have certain measurement tools, do you place too much importance on that measurement?
And I didn't understand that too. That's the thing. Like I did put too much emphasis on it. Probably was, there were a few other factors that were going on, that it wasn't just that led to it, but the coach was pretty nervous about him playing too. That was the other thing.
But it's interesting though too, because I feel like you have to be careful with this, but those subjective components, of knowing the individual or the player, understanding current circumstances, they're actually very influential for how that person actually performs in terms of their neuromuscular system and their susceptibility to injury. But I think that can also be problematic because people are very quick to dismiss anything that is non-quantifiable in that sense.
Well, it's interesting. At the moment I'm reading a book called The Expectation Effect, and it's essentially a lot of this stuff that we're sort of skirting around, which is people will behave in alignment both from a physiological perspective but also a psychological perspective based on the expectations that they carry.
Well, this is the concept of allostasis that we've talked about before.
So if you ask a player, do you think you'll be okay to play this game? Generally, and if you can trust the player, sometimes you can't. Sometimes you can. No, but you know the ones that you can.
I know what you mean. Yeah, you're right.
Profile them.
You know the ones that you can, the ones you can't, especially if you've got good rapport with them. And you say, mate, do you genuinely think that you're right for this? And they'll say, yeah, I think I'm okay. And most of the time they actually are able to get through that. And what's interesting about that is they're starting to show, and there's lots of evidence, and they present lots of even like placebo evidence, but they talk about if you have this expectation that you will be okay, it actually starts to alter your physiology, and that obviously is going to affect your psychology. And so, as Jack said, we don't maybe trust that subjectivity of the individual, but maybe we need to sort of find a way of that influencing what we do, as long as we trust them enough, because it's probably pretty accurate. And it's interesting you say that about the wearables. Like, as you know, I coach, and I've been trying to get more and more data And there's a few different systems I use, and I'm testing out all different ones to see what I get. And sometimes you get really aberrant findings on there, yet they train really well. And you go, okay, I need to look more at the trend rather than the individual data that I get for one day. But it's interesting to see that, like, typically what aligns more is what they say to me. Like, if they say I feel pretty good, they usually are going all right.
Yeah.
It overrides actually some of the measurements that I get.
But see, that's the thing though, that it's also using the measurement systems consistently.
Yes.
And so
it's trends. You've got to look at trends.
Even you understanding that aberrance is normal. There's a story about when they invaded on D-Day, when they invaded Normandy.
You were a historian.
No, I just heard this one. It was interesting because it was all about measurement. So there was Eisenhower was trying to work out the big issue for them, and it's always been an issue in war, is crossing the English Channel. And like there's lots of times that the French tried to invade, or lots of people tried to invade England, but the weather knocked them away. I mean, the whole Spanish Armada thing was they got the weather wrong. So anyway, Eisenhower gets an expert who's a forecaster. But what he does is he gets the forecaster to make a prediction, I think every day for, let's say, I'm going to just pick a number, like for 2 months. And why Eisenhower did that is he wanted to know in his own head how accurate was this measurement. Like, is it enough to just believe it, or do I need to understand what it means?
It's interesting. Have you ever seen any of Philip Tetlock's work?
No.
So Philip Tetlock is an academic, but he's done a heap of research into prediction and forecasting.
Yeah.
And
it's actually interesting related to the topic of...
It is. Yeah. It is interesting. We spoke about this before, but he's got a really good book for the general populace if you're interested. But his book and his papers talk about this concept that as experts get more experience, their biases get so strong that they actually become worse at their predictions and forecasting than novices, or people who are early on in the profession, and it's because of biases. So I believe it was an Atlantic article, but he said, experts are about as good as a chimp throwing darts at a dartboard in terms of their predictions. But what he said was, he actually does this, and they've run this, I can't remember what it's called, but they've run this competition each year for a number of years to see, actually, are there people who can forecast well and can predict with some level of success? And what they found is, there are, and there are people that practice it, and it requires a very specific process. And the process, we laugh about it because when we talk about complex systems, there's a number of people like Dave Snowden, who talk about how you actually, I can understand how to work within that complex space. And these people use this process. What they do is they'll take lots of sources of information. They constantly update what their forecast is. They think very probabilistically. So they'll say, there's a 65% chance that, such and such is going to, Russia's going to invade, Ukraine, and based on this and this and this and this. And they're constantly updating it based on the information that's coming in. And he said because of that, they tend to get more, like there are people that get very, very accurate with their predictions and their forecasting capability. But that's not actually what we get taught to do. We don't necessarily get taught to think very probabilistically, and we don't get taught necessarily to think in a way where we're constantly updating the information. And we actually had this conversation with a couple of barristers. We said one of the really interesting things, and one of the things that I struggle with actually conceptually as a practitioner, is someone comes in, especially as a physio, someone comes in and you do your assessment and they want to know everything about it and they want you to get an accurate diagnosis there or then, otherwise you're rubbish.
Yeah.
Whereas if you're a lawyer, you could be the best lawyer in the world and they come to you with a problem and you go, give me 2 weeks, I've got to research this. Could you imagine how easy it would be to get the right diagnosis if you had 2 weeks to research it and do all the tests you want and get all the information and gather all this? You're like, okay, well, I'm 95% certain I think it's this injury, right? You don't get given that opportunity. And the thing that we spoke about a lot was the difference between, as they go, they actually do a lot of expectation management, which we don't necessarily talk about as practitioners or even educate young practitioners on, explaining to a patient, okay, I believe it's this, but we're going to go down this path, and then if I don't have that information, I'm going to do this, And then our plan B is to maybe go on to speak to the sports doc or the surgeon. And I've started doing that more, but there's a weird balance because, as I said, if the lawyer does it, they're a great lawyer. If the physio does it, or even maybe the doctor, they go, does this person not know what they're talking about?
Yeah, exactly.
Why are they handballing this up the chain? Like, are they not that good? Whereas I think we should see that as a strength, your ability to update your position and update what you're working on based on what information is coming in.
But John, when you do it though, like you're getting people come to you that already trust you.
And that's the benefit that I have.
Yeah,
right?
Exactly. Because people would go, they go, well, if John says it, that must be right.
I understand that, but what about practitioners who I think it's the right thing to do, but they don't have maybe the credibility because they're a new graduate or whatever, and they're actually doing the right thing. They're actually saying, oh, I'm going to, say if they work at Mill Park, they go, oh, I'm actually going to defer to Cobes or Tanya or one of the senior guys like Jamin, and I'm going to ask them, I'm going to get them to come in. It would almost come across as if they're undermining themselves, but they're actually doing the best thing for the patient by a mile.
Yeah, you're right. And you know, we've never had in all the times we've done that in our clinic, I've never ever had a patient say, actually, I don't want to see that physio anymore because you know more. Never, ever, ever. Would you agree with that, Jack?
Yeah, no, I never had that. Well, not that I'm knowing, they've told me knowingly anyway. But I think also part of it, I think, is how you actually message it to them, because I think that was a big issue that I had for probably a long time. I'm like, you're kind of a bit like, I think you've been on the fence about it all, as opposed to saying, look, I think there's a high probability that this is the case. I think there's actually a low probability that it could be this as well, but I don't think it is because of this and this. However, if I don't see these changes in the next 2 or 3 weeks, we probably need to rule that in or out. And I've found actually a lot of people do respond to that really well. Yeah. Because I think it's interesting. I think it can be quite useful when you go, this is what you got, this is exactly what we're going to do, and you're going to be right in 3 weeks. And the patient goes, fantastic, I'm going to do exactly what you tell me. And it's funny, I think it's probably one of the benefits of specialization, because you obviously become more confident with what you know in that area, and that actually comes out in your behavior and your personality. And I think that can be quite a powerful tool on patients.
Yeah, it's like that placebo.
Oh, this person knows what they're talking about. But you also see that probably in young physios too, where you might have the ones who are a bit like, you have the other ones who are like, I know everything, this is what you got, and we're going to sort you out. And it's not until you start actually getting some misdiagnosis. And
you make some mistakes, you go, oh shit.
You actually start to pull your head in a bit.
Yeah.
That just depends on the individual's personality.
Well, it's funny because like with surgeons, they're saying that they should be giving patients all the information, right? About, what the risks are, etc. But the thing is, there's also that, there's that phenomenon where, Thinking Fast and Thinking Slow, that book.
Daniel Kahneman.
Yeah, that's the only book I'm about to refer to. Yeah. You're trying to keep up with you, makes references to books. But
John seems to have this memory of just...
I know, it's frightening. It's throwing me off in this conversation, John. I'm struggling a bit now.
He throws me off in general. That
has nothing to do with books.
Sorry.
So... what he says is that, and it's not, he didn't make it up, that things that we're frightened of stick more in our heads and have more of an influence on what we're thinking than things that are positive. And that, there's some, he's done it, he's been able to quantify it, that, I think it's like, if it's got a quarter of the danger than something that's got benefit, like 4 times the benefit.
Yeah, they do they're all the experiments of like loss. So what they'll do is they'll give someone money, and then they'll say to them, all right, would you give us X amount of dollars to take it away, or whatever it is. I can't remember how the experiment.
No, you're right. That was
it's always about money. So it's always like, would you? And it's always that thing of like, if I give you $10,000 now or $1 million in 5 years, which one do you want? And people will take the money now a lot of the times because the benefit of having it there and then is greater than having to either wait or the negative time period or whatever it is. So and they quantify it. It's like, it has to be like more than 4 times or something like that for the negative to outweigh the positive and all those kind of things.
So when the surgeon says to when we say to someone, oh look, this could happen, but there's a slight chance, you'll die under anaesthetic. A lot of people cannot get away from...
Well, this is actually, during COVID, I spent a heap of time, because I had time, I started actually writing a book, right? And one of the things that I delved really heavily into was around bias. And there's a number of really good studies that have been done looking at practitioners and, the discussions that they have and the bias that they create. And you're 100% right. People's ability to think probabilistically is extremely poor. So if you tell a patient it's a 1% chance that you'll die, they don't understand that probability is 1 in 100.
No.
Right? So it's like, okay, well,
you could die.
I've done 1,000 and 10 have died, but it doesn't compute to them, and the numbers are actually much more vast than that. And if you're interested in this stuff, actually, the person that did he did a general populist book is a Gerd Gingerenzer. He's a German
you have to do this
scholar.
every week. You have to sit
Well, Jack normally does
every
it to
week.
me with all of these physiology papers.
Yeah, well.
Go on.
But Gerd Gingerenzer has done some really cool stuff, and he did a couple of really good papers on this probabilistic thinking for patients and how they don't really understand. So if you say to them like a 1 in 10,000 chance, they really can't compute it. They think that's high. They're like, I'm going to die. And it's like 1 in 10,000 is extremely low for a surgical procedure. Like, you're going to be fine. But they don't know how to compute that because as we spoke about even in prediction, we don't learn to think probabilistically. Even as practitioners, we don't really learn to think probabilistically. So for the patient, it's really confusing. He spoke about a couple of different processes, which maybe you talk about, like actually quantifying that into real numbers for real people. And it's like, this is very unlikely for you, or this is very likely for you. So what decisions you want to make? And it's difficult because I don't think that we necessarily in society communicate that way.
John, I reckon as even as health professionals who know this, when it's us, we can do exactly the same.
Yeah.
The number of clinicians I've seen who give all this advice about, you shouldn't have surgery, you shouldn't have that, and then they end up doing it themselves. You think, oh God, what's the, I've one of the.
I just remember it's loss aversion is the bias, loss aversion.
Yeah, and we all do it. It's our biases. It's really hard to get your head in that objective probability perspective.
I think, and it would be obviously, I think that's probably what you guys try and develop with some of your frameworks, is to take away from people making those errors. You've actually given them some kind of at least decision-making trees or ways in which they don't necessarily step too far outside that, because then potentially they are making errors that they don't need to make, or they're not applying the treatment model that actually has been shown to be more effective.
Yeah.
I know you mentioned this in your email, but like talking about exercise as being essentially a panacea for so many conditions, but there's the issue of the general population not interested in doing it. Is that something that you've looked at or thought about how you actually promote that? Like, how do we actually get improvements in people's physical activity, whether that be, let's not talk about in general, but just say specifically related to compensable patients and following injury?
Look, as you would be aware, that's more of a science now. It's not more of, it's totally a science about compliance. And some of it's about how even urban planning is developed. My 17-year-old daughter's telling me that you need to have towns and urban areas constructed so people are more inclined to exercise. But going back to it, in terms of one of the things that we face at the moment is one of the great good areas is some of these group programs where people do exercise in a group and it's social and
I think one of the good things, though, at least in Australia, exercise is seen as being a beneficial thing, and people are not necessarily discouraged from exercising. You see people running down the street, you see people riding their bike, and it is generally considered a good thing to be healthy and trying to do exercise.
Yeah, but
right? Not always, and not in some, particularly in some areas. It's not, like particularly in low socioeconomic areas.
Yeah, that's what I'm thinking.
They're discouraged. But to be honest, and it's one of the things that I noticed about when you travel around the world. In some places, you don't see people exercising at all. In Australia, you always see people exercising.
Yeah.
It's very common to see people just going for a run or walking their dog or on their bike. So at least I think that is one thing that is in our advantage.
Yeah, but it's interesting. You just raised something earlier on about exercise, and that was the evolutionary...
the evolutionary mismatch between...
Yeah, the evolutionary mismatch. The other evolutionary mismatch is that to sit around and do nothing when you didn't have to was really important because you're trying to conserve energy because you may not get that food. So it's a massive drive we're trying to deal with.
Well, it's probably one of the big problems that you're dealing with a lot with, clinically speaking, is the fact that most people don't want to do physical activity, and two, most people don't want to push themselves out of discomfort.
Yeah.
And I think particularly in the presence of pain and the expectations about pain in conjunction with rehabilitation, where you may not see that effect immediately.
I think that's one of the hardest things to get across, particularly in the
doesn't make sense, does it?
Like, you're saying to them, you need to do activity, and they're like, my back hurts. Like, do you not understand my back hurts? And you're like, I understand that it hurts, but if you start to do some movement and some low-level physical activity, it will start to feel better a lot quicker than if you sit there and do nothing.
Well, this actually probably comes back to the point you made before, Cobes, talking about technology, where you actually need to have... That's probably the benefit of having more immediate technology in the phone, of being able to have that in your phone, of put in, okay, you've done this today, I want you to actually measure your pain tomorrow morning, and they get up and like, oh, actually,
it's a 4 instead of a 6
today.
Yeah.
That's probably where the biggest benefit's going to lie, of actually having a way to objectify it and see that pattern.
Because they won't, as Cope said, they won't remember it.
Well, and, I mean, to me, it was I'm not even that good at it. Like, I even think of it.
So you say, ask someone, what did you have for dinner 3 nights ago? And they're like, I don't know.
Well, it's even recently, for instance, I've had some pain in my body because I've been getting up earlier, so I've been sleeping less, I've been doing less physical activity and sitting in front of a computer. And I'm like, geez, my neck's sore, geez, my back's sore. And I realised, yeah, okay.
Yeah.
I've actually changed a few lifestyle factors. Like, it's not like I've changed my mechanical load, but it's an underloading issue, not an overloading issue.
Right. Yeah.
Was there anything else that you guys wanted to venture into? We've done pretty well. It's an hour and 10.
Oh, is it? Oh, God, it's fine.
Well, I mean, I'm just having a look at what you covered. You put down scientific literature in the field of physio. We've covered talking about biopsychosocial model, measurement systems. I'm sort of happy with everything we've covered.
Yeah, it's good. It's really good. I think it is exciting as to what's going to happen in the future in this field. And look, the other thing is going back to what happened, going back to the start of my career, the wonderful thing is that exercise has become this amazing panacea. And I don't think we saw it to the extent that I think we believed in it, but it was more like a religion than a science.
Do you think there's a next crest? Do you think there's something else that's going to continue to transform the profession? And I'm saying that actually completely oblivious. I'm just asking, given for someone who's
I think
seen
individual measurements are big. I think measuring people on their performance rather than saying I'm an evidence-based practitioner. Because I have seen people who are really good, and I don't know what the hell they're doing, but they just connect with their patients and they get it. I remember Cody with some of the work cover patients. One of the physios that worked with us, and you know him well. I'm just saying the benefit.
John knows Cody well too. Yeah.
But I mean, the way he could convince, sometimes his impact was far greater than what he was. Well, a lot of time, his psychological impact was far greater than what he was actually doing.
I think also too, Cody was really good at just saying like, shut up and do it, basically, and he really actually pushed people. Like, I think something that Cody was good at is he's like, I'm going to push you to get better.
Yeah.
And I think he was really good at like really applying a stress to the system that's actually quite positive, and whether that's related more to specific structural changes related to the area of pain or more just the overall systemic effect. It probably more the latter, particularly in that, say, general population group. But
yeah, and so that's that one.
Yeah.
And the other one, in terms of things that will make better, I think is understanding our measurement systems.
The question I have for you on the individual stuff, because we agree with you, right? We think that individual medicine and individual healthcare is the thing that will drive it. How do you think that will be impacted by some of these more protocol and evidence-driven systems? Because to us, that's kind of the antithesis. You don't want to apply a general protocol just because it's based on the evidence if the actual information you're getting about that patient differs from what that protocol says, right? Like, the thing that we struggle with a lot, say if we go back to a really basic example of the hamstring, we work by the concept of again, using some of these complex systems model of, we run what we call safe to fail experiments. So if they can do this, we'll move them to this.
Yeah,
if they can do this, we'll move them to this.
Yeah.
And you make those jumps small. Right?
Based on your assessment.
And that evidence is coming in. It's like we're talking about that,
Yeah.
when we talk about the TETLOC stuff, the reason I bring that up is that's informed our practice, because we go, okay, I've received a little bit more information. I'm altering my prediction from here to here. I thought they were capable of running at 70%, but actually I've got information that says that their rate of force development in their hamstring testing is better, and they're telling me they feel good with this, and I'm seeing that they can carry out this drill. I'm actually happy for them to go to 80%.
Yeah.
Even though on the timeline that I followed from this protocol says I should only be at 70% because they're X number of weeks post grade 1 or grade 2 or whatever you want to do. But I'm using that information. And to us, we think that that's appropriate, right? But if you're following, the evidence-based protocol, you're actually stepping away from that.
Or the evidence protocol.
Yeah, the evidence protocol.
Not the evidence-based.
Yeah. How do you see those two things aligning? Because typically, even when we have students in, they get really rigid and they say, oh, the evidence says this, right? And we push them and go, well, if they can do that, why would you not allow them to do this?
The other thing too is I think that works both ways, because one, what like John's describing is, what's the emergent pattern? Do you see them heading in the trajectory that you want? But at the same time too,
if they're not,
you also see times where okay, this actually isn't working. Like,
well, that was
what do we
exactly.
need to change?
That was one of the things that I think that I was astonished with some of the discussion with Brady, was it sounded like, even at the high level of being in a professional sporting club, that they were following these stepping stones, irrespective maybe sometimes of the information that was coming back to them that said they weren't ready for that. But they're like, no, you're 6 weeks post. You should be able to run at this speed and kick, this distance and do this. And to me, that was like, well, that doesn't make any sense to me at all.
I think the issue with that too is understanding the difference between proximate versus ultimate causes. Like for instance, if someone has a soft tissue strain, you're going to see deficits in their strength, and you obviously want to restore that. But do you actually have a framework that allows you to assess all the other factors associated with this particular problem? Because, a basic example is with the hamstring strain or any soft tissue strain is maybe it's related to their tissue capacity, but maybe it's not. Maybe it's actually related to their metabolic capacity. Maybe they actually don't have the ability to maintain active stiffness throughout an entire game.
Like repeated sprints and
even
seeing that drop off. Yeah.
Completely. And it's like if you look at their strength, their strength is really good. That's not an issue. But what you're actually seeing is their ability to actually maintain the neuromuscular patterns and the active stiffness needed to maintain the integrity of the tissue
activity.
There.
Yeah.
So it's like you've missed the ultimate factor of being that they actually aren't conditioned to complete the task.
Not that you haven't done the actual tissue conditioning. Yeah.
So in answer to that, we developed the clinical framework nearly 20 years ago. It was 2003, so it's nearly 20 years ago. And when we did it, I was having come from sport and just managing lots and lots of patients. I was really worried that if we made some sort of if at that time, rather than having the clinical framework, with just 5 principles, right? 5 principles, 3 of which we've managed today. So measurement, biopsychosocial model, evidence, and we, a couple others chucked in, I talk about those. But what I was worried about was that what happens if we have a purely evidence-based program? What happens if the evidence changes and we're left stopping people progressing? So the clinical framework has not changed in any of its principles since we developed it, and it just says exactly what you guys are saying.
Yeah, use the principles.
You apply, principle 5 is the evidence, but principle 1 is measure what you're doing. And if someone is doing so-called evidence-based practice and that patient isn't getting better, we're going to cut the treatment. We're going to give a bugger about it. Well, when I say we're not going to cut it, we're going to question it. So you've got to be able to demonstrate a benefit. And I think that's really important. But what we haven't got to is it does leave wriggle room for those people who are not that good. And that's where I think measuring individuals' performance or groups' performance gets around that.
I think that's the big thing too in working in the real world is you're focused on outcomes. As opposed to research where you actually want it to be very controlled. Because you want to try and find that relationship between the independent and dependent variable. I don't really care, to be honest, about what necessarily works or what doesn't. And the reality is if you're using multiple interventions in parallel, you actually may have an interaction between how those interventions
Yeah.
create adaptations that leads to
A
exponential
beneficial,
or
yeah.
non-linear
Yeah, yeah.
outcomes. And I think that's one of the things too, with like going back to talking about evidence-based practice, where we're seeing exponential increases in research. There's a neuroscientist called Daniel Walpert. I'm dropping names.
Good,
so
yeah.
you see. And I've really enjoyed watching some of his presentations. He's a neuroscientist who does work on the sensory motor system. And he talked about this in one of his presentations he published a textbook like 15, 20 years ago.
They did a good TED talk.
He has, yeah. He's done a few really good talks on YouTube. And he talks about when they did that textbook, there was, 800, well, wouldn't have been 800, maybe like 2,000 articles in the particular topic that he is an expert in. He goes, now there's like 90,000.
Yeah.
And so he shows this graph of an exponential graph. And he's like, the thing that we actually need is we need people to be able to identify principles and patterns that emerge from the research. Because once you actually do that, you don't necessarily need to think of, have I read actually every article? Because a lot of the time you're going to see the themes and patterns that emerge from the research of this actually may be effective in this context for this type of population group, and this may not be effective. And I think that's probably one of the big things that I try to aim to do is like, well, how does that research inform what I'm doing, and how does it actually relate to the basic sciences as well? Thinking about what particular behavior of, say, tissue influences the actual adaptation that you get.
Yeah, I think it's good. It's a similar sort of thing.
Should we finish it there?
Yeah. So.
All right.
Thanks for having me.
Thanks, Cobes.
This episode of Lateral Think is brought to you with the support of Strength by Numbers. Strength by Numbers have created an integrated clinical and sports performance system. The AXIT system uses force plates, dynamometry and strain gauges to objectively measure everything from isolated movements to sports performance tasks. The system has greatly enhanced our clinical practice, decision-making and objectivity. We are no longer guessing. The greatest thing is ease of use, both for practitioners and clients. There are no wires, no fixed setup. It is a fully integrated Bluetooth system. If this sounds like something that would enhance your practice, visit strengthbynumbers.com and tell them that Melbourne Athletic Development sent you. Thank you for joining us, Cobes.
I feel like we've just done an advertisement for that.
We have.
We have.
Thanks to Strength by Numbers.
Good on your Strength by Numbers.